Hello, good morning, and welcome to the AMA Future of Health Immersion Program, part of the AMA Steps Forward Innovation Academy. My name is Laura Fritchie. I'm a project administrator for the digital health team here at the AMA. May is Women's Health Awareness Month, and so to close out May, we have a series of presenters that will be discussing their work in women's health, specifically around digitally enabled care. Also, with the end of the public health emergency that was on May 11th, we'll spend a little time discussing what this means for women's health. Here's a quick disclaimer. As I mentioned, we'll kind of discuss the end of the public health emergency. We'll have a few physicians speak on a physician perspective on their work around digitally enabled care for women's health. We also have a company with us that will share their work, and then we'll do a wrap up and close. If there's time for Q&A, go ahead and put them in the Q&A chat here that you see. If we have time, I'll pull some, but if not, we'll probably just wrap up and close. Here's our list of presenters for today. We have Taylor Platt from the American College of Obstetricians and Gynecologists, Dr. Gillespie Bell, Medical Director of Quality Women's Services, an Associate Professor and Senior Site Lead Women's Services at Ochsner Kenner, Dr. Fox, Maternal Fetal Medicine Physician from Scripps Clinic, Dr. Ajayi, Director of Clinical Research at the Scripps Research of Transitional Institute, and Anish Sebastian, co-founder and CEO of Baby Scripps. They'll all be presenting today, and we'll kick it off to Taylor to speak a little bit from ACOG's perspective.
Thanks so much, Laura. Good morning, everyone. My name is Taylor Platt. I'm a health policy manager at the American College of Obstetricians and Gynecologists, and I'll be talking a little bit today about the end of the public health emergency and the tie into reproductive health. Before we begin, I do want to make a quick note about the language that I'll be using throughout the presentation today. By and large, I will be using the terms women and mothers to describe people who are pregnant or who recently experienced pregnancy. We use these terms because they reflect the language that is used in federal statute to describe Medicaid eligibility. That said, ACOG does acknowledge that not all people who experience pregnancy identify as women, and we continue to encourage use of and are committed to using respectful and inclusive language. So just a little bit about the American College of Obstetricians and Gynecologists, or ACOG. So we are the premier professional membership organization for OBGYNs, and we have more than 60,000 members. We do produce different practice guidelines for healthcare professionals, like educational materials, and also our clinical guidance documents for healthcare professionals. We provide practice management and career support. We facilitate programs and initiatives to improve women's health, and we also advocate for our members and patients. So just a little bit of background on the COVID-19 public health emergency. We have a timeline here of some of the major emergency declarations. So a public health emergency, or a PHE, was initially declared by the Secretary of the Department of Health and Human Services, or HHS, in late January 2020. A separate emergency declaration pursuant to Section 564 of the Federal Food, Drug, and Cosmetic Act was issued by the Secretary of HHS in February of 2020. And this emergency declaration had the emergency use authorization for medical countermeasures for COVID-19. So this included things like treatment, vaccines, as well as COVID-19 tests. One thing that I do want to highlight is that emergency use authorization for treatment, tests, and vaccines. There is no current end date for that. It was not tied to the end of the PHE, which happened on May 11th. There was also a national emergency declaration and then a declaration under the PrEP Act, which had different things to help providers and to help our emergency response to COVID-19. And as Laura mentioned earlier, sorry, I'm not sure why the slides are advancing on their own. I'm having some trouble with the slides. Okay. I think we're set now.
Okay.
Okay. Sorry about that. So the COVID-19 public health emergency ended on May 11th. And so I just wanted to quickly go through some of the changes to telehealth that came with the end of the public health emergency on May 11th. So this slide has information on private payers and Medicaid. So for private payers, telehealth policies are going to vary by plan. And for Medicaid, it's going to vary by state. The flexibilities that became available to states around telehealth, including modalities and originating site, were always available to states prior to the pandemic and will continue to be available to states when the PHE ended. I just want to plug the Center for Connected Health Policy. They have a really in-depth state-by-state tracker on how Medicaid agencies are handling the telehealth changes with the end of the public health emergency. So for Medicare, there's different changes that we're going to see at different points in time. So there are a few permanent changes that we're seeing with telehealth. For example, coverage of two-way audio video telecommunication, and also coverage of audio-only telephone for evaluation and management services. And then there are some changes that are ending 151 days after the public health emergency ended. So 151 days from May 11th. For example, reimbursement for audio-only E&M services. And then we do have some of the CPT codes listed there. And the extension of temporary telehealth codes coverage, as well as the addition of the 54 codes that were added to the Category 3 Medicare telehealth list. And then there are some changes that are ending at the end of 2023. And so this is the use of virtual direct supervision, as well as the use of modifier 95, along with the place of service code that corresponded to where the telehealth service would have been furnished in person. So I do want to take a moment to talk a little bit about the end of the continuous coverage Medicaid provision. We have another timeline here. So again, we had, and this is focusing on the Medicaid provision. So we had that PHE first declared in 2020. And then I just wanted to highlight some major pieces of legislation that correspond to the continuous coverage provision. So the Families First Coronavirus Response Act, which was passed in March of 2020. This bill had the continuous coverage provision for Medicaid, which basically meant that states were going to receive an increased FMAP for their Medicaid program by 6.2 percentage points with the condition that they would no longer be disenrolling individuals from Medicaid. So there was going to be continuous coverage, no eligibility determinations, and they would continue to receive that 6.2% FMAP increase for the duration of the public health emergency. In March of 2021, the American Rescue Plan Act is passed, and this has some really good incentives for states to expand Medicaid, as well as it creates a state plan amendment option for states to extend postpartum Medicaid coverage to 12 months. This past December in the Consolidated Appropriations Act, this is important because it decouples the end of the continuous coverage provision from the end of the public health emergency. So this sets an end date for the continuous coverage provision in Medicaid to March 31st, 2023, regardless of when the public health emergency ended, which we know ultimately ended on May 11th. So what does the continuous coverage provision mean? By preventing states from disenrolling people from coverage, the continuous enrollment provision has helped preserve coverage during the pandemic. Estimates from HHS suggest that as many as 15 million people will be disenrolled, including 6.8 million people who will likely still be eligible. While the share of individuals disenrolled across states will vary due to different renewals, it is expected that the groups that experienced growth due to the continuous enrollment provision, like the ACA expansion adults, other adults, and children, will experience the largest enrollment declines. These eligible individuals are at risk for losing coverage if they don't receive or understand notices or forms requesting additional information to verify eligibility or do not respond to requests within required timeframes. And I just want to point out that those 6.8 million people that are estimated to be disenrolled, they will be disenrolled because of administrative issues. Sorry, I'm not sure what's happening with the slides. So what does this mean for pregnant and postpartum individuals? This does mean that any person that was eligible for Medicaid based on their pregnancy or postpartum status as of March 2020 will be required to have their eligibility status redetermined. So as of April 1st, states have begun to disenroll those no longer eligible. And this does mean that there's potential coverage loss and gaps in coverage for people. So what if your state has extended postpartum coverage? So this means that instead of a postpartum individual losing their Medicaid coverage at 60 days, it means your state has chosen to extend postpartum coverage to 12 months. So 33 states and Washington, D.C. have approval from CMS. And Delaware, this map is slightly outdated. Delaware just recently received approval as well. 10 are in process. That's that green color, with Alaska and Missouri as new additions. We're just waiting on some governor signatures. I do want to point out that the light green color on the map does mean that the state has some limits on eligibility or time frame for their proposed extension. For example, Texas has proposed a 6-month extension and Wisconsin has proposed an extension to 90 days. So it's important to know the status of your state's extension on postpartum coverage, because it does mean that as the unwinding of the continuous coverage is happening, pregnant and postpartum individuals in your state will retain their coverage for 12 months after delivery, regardless of the unwinding. So what can you do as providers to help ensure people continue to have access to coverage? Ensuring patients have updated their contact information with state Medicaid agencies is really important. It means they'll get those notices, they'll be able to respond to those notices as soon as they receive them, and also letting patients know that they should keep an eye out for these notices as well. And also, if a patient does lose coverage, marketplace plans are more affordable than ever with recent actions from the Biden administration. They can find little to no cost coverage at healthcare.gov. And there's also a special enrollment period for marketplace plans for losing Medicaid coverage during the unwinding. So they'll be able to access coverage quickly. I do just want to plug some of our ACOG resources. We do have an end of the public health emergency website that has a lot of information. And we have a specific page on the Medicaid unwinding that links out to state-by-state resources. So for example, we link to the Arkansas Medicaid page that may have flyers you can hang in your practice, depending on what state you're in. We have a resource on telehealth and some of those changes that we're going to see now that the public health emergency has ended, and then changes on coverage for COVID-19 testing, vaccines, and treatments, as well as we have our state tracker on Medicaid postpartum extension. And I will turn it back to Laura.
Thank you,
so
Taylor. I'm sorry for the technical difficulties with the slides. Not sure why they're progressing, but bear with us. I'm going to now pass it to Dr. Gillespie Bell to share a little bit about her work in this space.
Thank you so much, and thank you all for joining. Thank you for having me. I'm happy to share the work that we've done at Ochsner in the digital enabled care for women's health. We are located in the New Orleans, Louisiana area, and really across the state of Louisiana. I think it's important to make sure we're all on the same page and think about what telehealth actually is. So this is the definition from the National Consortium of Telehealth Resource Centers. Telehealth is not a specific clinical service, but rather a collection of means to enhance care and education delivery. And there are different modalities. We have things like remote patient monitoring, virtual visits, and also mobile healthcare. Today, I'll focus from the Ochsner perspective on what we've done for remote patient monitoring as well as virtual visits. So why use telehealth? There are several advantages that are cited in the literature, and also advantages that I can tell you from my own personal experience. When we think about convenience, telehealth allows us to bring care to the patient instead of the patient coming to care. And that's really important when we think about our patients and we think about a lot of the barriers to accessing care. And there's been literature and research and data that shows that transportation and childcare are the two biggest social determinants of health that can create barriers for individuals being able to access care. And telehealth allows us to overcome some of those barriers. I think there's also convenience for the providers. We know that for providers that have busy schedules, sometimes that is also a barrier for patients to be able to access care. And so this allows providers to add in some visits, or at least it has for me, when we're doing telehealth, to create some more access. And we see that outcomes are comparable or better when we use telehealth. When we look at things like blood pressure management, there is data that shows there's increased compliance as well as decreased hospital readmissions when we're using telehealth. And it allows for continuity of care when traditional systems cannot be used. As I was mentioning as we were getting ready for this call, today or tomorrow starts the first day of hurricane season here for us in the Louisiana, Texas, Florida area. And so having telehealth has been really beneficial to my patients and to the patients that we serve through Ochsner, through some of the challenges that we don't expect, like weather. Just as a prime example, Hurricane Ida affected most of southern Louisiana, including the area where I see patients a year ago. And with that, our patients had to evacuate. And if you can imagine, if you are pregnant and now you're having to go to another area because you've had to evacuate and not knowing how you're going to continue care, that can be overwhelming. So because we have a telehealth system and this has been in place, I was able and we were able to have a lot of our patients flipped to virtual visits. And because of some of the remote patient monitoring that I'm going to discuss in a minute, we were able to still provide care. And not only did my patients have to evacuate, I had to evacuate as well. And so I was able to be able to continue care with my patients. And so when we think about disasters such as hurricanes, or we think about pandemics like COVID-19, having telehealth allows us to give that continuity of care when our traditional systems can't be used. And with telehealth, there's data that shows we have patient and provider satisfaction. Ooh, sorry, I think I clicked the wrong thing. Okay, there we go. So to think about obstetrical care in Louisiana, and we're not unique. I think this is very common when we think about this landscape, when we look at southern states in general, but just to think about Louisiana specifically. More than a third of Louisiana has been considered by the March of Dimes to be a maternity desert, meaning that there is no obstetrician, there is no birthing facility per 10,000 live births in that area. And so again, thinking about those deserts, those individuals that live in those areas may not be able to access an obstetrician in their area. They may be having to travel long distances just for prenatal care. 34 out of the 64 parishes, we use parishes instead of counties in Louisiana, but counties are how it's classified across the rest of the United States, but 34 out of our 64 are considered to be rural. So in addition to having these deserts, and most of these deserts are rural areas, in addition to that, we have rural areas with decreased access, even if they are not considered a desert. So there may be an obstetrician, but it may be the only obstetrician in that area. And then more than 60% of our births are to individuals with Medicaid as their insurance provider. And you just heard it from my co-presenter from Taylor, what that means and what Medicaid coverage and the changes in some of that coverage it means for being able to access care. And when we look at our obstetric outcomes in Louisiana, one of the roles that I have outside of Ochsner, I'm the medical director of our maternal mortality review committee, as well as our perinatal quality collaborative. And so we're constantly looking at our data and looking at our obstetric outcomes. And looking from 2017 to 2019, the leading causes of pregnancy-related deaths were cardiovascular conditions, thrombotic embolism, and hypertensive disorders of pregnancy. And 61% of those pregnancy-related deaths, so in this category, were occurring within the time of delivery up to the first 6 weeks of delivery. So when these patients had already left the hospital. And then 80% of those deaths were deemed to be preventable. So when we think about our treatment landscape and we think about those barriers, we have to do more to make sure our patients are able to access care, especially once they have left the hospital. And so what we've done at Ochsner is we have two programs. One, the first one I'm going to talk about is Connected Maternity Online Monitoring. And so this is Connected Mom. And so it's our obstetrical digital medicine program. And it was really modeled after what we have done for digital hypertension. So it launched in 2017. And what it consists of is a remote patient monitoring system, a Bluetooth-enabled blood pressure cuff, as well as a Bluetooth-enabled scale for being able to capture weight. And so patients are able to take these devices home. We do not charge anything for patients to participate. We supply the devices. And so they're able to monitor their blood pressures, able to monitor their weights. It uploads through their Bluetooth-enabled phone or their smartphone to the electronic health record. And then on the receiving end, are able to monitor all of those vital signs. If there are abnormal vital signs, the patient gets a text message, and then also the office is notified. If the patient gets that first abnormal reading, they're instructed to take their reading again, and if it's abnormal, then they're instructed to come to the hospital. So again, just that extra monitoring, those extra set of eyes. For those patients that forget to do their blood pressures and their weight, they get text messages until they do deliver those vital signs. So again, there are many ways through this system that we're making sure that patients are compliant and that we're also sending reminders. Also, as a part of this program, as I previously mentioned, we do have virtual visits. So with the virtual visits, we have a platform similar to the one that we're using today, where we're able to connect with patients. And so on the receiving end, they're able to see the provider, hear the provider, and we have that audio visual way of delivering care. And again, for the times that we have had to have disruptions in our services, we're able to capture those vital signs through the remote patient monitoring devices and then being able to do those virtual visits. So again, when we think about convenience and we think about those barriers to accessing care, this is bringing care to the patients. But convenience is not the only goal. We need to see that we're having improved outcomes. And so when we have looked at our patients that participate in Connected Mom, and specifically for those that have a hypertensive disorder of pregnancy, those patients that were in Connected Mom were twice as likely as those in traditional care to have blood pressure monitoring during pregnancy and during the postpartum period. I've already mentioned here at Ochsner, or excuse me, here in Louisiana, that we're finding that the majority of our pregnancy-related deaths are occurring from the time patients are discharged to that 6 weeks postpartum. And hypertensive disorders of pregnancy are one of those leading causes of pregnancy-related deaths. And so again, thinking about why the stats are the stats and why we're seeing those outcomes, thinking of ways to close some of those gaps. The second program we have is called Telestork. So Telestork is Ochsner's program that provides 24/7 monitoring to laboring mothers via live stream of maternal and fetal health records. And so we have nurses that have more than 30 years of experience sitting in a bunker. We call it a bunker, but if you know anything about Louisiana, we are below sea level, so we do not build anything underground. So it is not an underground bunker, it's really just a room. And this is just a picture of the bunker here, where we have a nurse that is monitoring multiple fetal tracings and maternal tracings from our hospitals across the health system. As I mentioned, our primary hospital is in New Orleans, but we have hospitals throughout Louisiana as well as in Mississippi. And so we are able to have that second set of eyes on those fetal heart rate tracings as well as those maternal vitals. Again, when you think about the treatment landscape in Louisiana, and we think about a lot of our community being rural, when we think about what is happening right now with the nursing shortage, this allows just that extra set of eyes to make sure we are acting quickly on abnormal fetal heart rate tracings as well as maternal vitals. And so what we've seen since we've implemented TeleStork is a 27% reduction in unexpected NICU admissions for term infants and an 8% reduction in C-section deliveries. And so this is a system where, again, we're having that extra set of eyes when we're trying to think about the barriers that we have in healthcare in Louisiana. Now, while I have presented what we have here in Louisiana and what we're using at Ochsner and presented some very positive results, we always have to think about telehealth and not think about it in a vacuum. Telehealth is great as a tool, but it's a tool. And we have to think about those barriers to telehealth. And I would propose that there are always three: access, affordability, and digital health literacy. With access, we have to think not just about the devices. And again, we've overcome that barrier here at Ochsner because we provide those devices to our patients. But we also have to think about access in terms of broadband. This is one of the reasons the FCC is wanting for broadband to be considered a social determinant of health. And if you don't have access to broadband, then you may not have access to telehealth and all of the benefits that we've discussed. We know that we have disparities in our outcomes across the country in terms of Black women having worse maternal outcomes. And we also know the outcomes are worse in our rural areas. So if we don't address barriers to access, we are going to see that disparity gap get even wider. For us in Louisiana, with the platform that we use at Ochsner, we've not seen any issues with access. We do implement both TeleStork and Connected Mom in rural communities. And I will say our governor has also been a very big supporter of making sure that all Louisianans have access to broadband. And so we have not seen barriers to our patients being able to access our telehealth systems. Other barriers, affordability. Again, for us, we are giving those devices to our patients, but we do have to think about a model that is sustainable, because as we grow as a health system and we continue to have more patients enroll, we may not be able to continue to provide those devices free of charge, depending on what reimbursement looks like from our payers. And then it's important to always access digital health literacy. There's literature that does show that there are different individuals based on age and sometimes looking at data on race that may not be as comfortable with using digital health services. And so we want to make sure that we are addressing that. I know for us, again, here at Ochsner, we've made sure that we have made all of the information and the literature available in multiple languages, and also making sure that we are not giving literature that's more than an 8th grade education level, to make sure from even a general health literacy area that we are addressing that barrier as well. And then considerations for providers, and this comes directly from ACOG. We want to make sure that we understand the laws, both state and federal, for what we are able to provide through telehealth, and also where we are able to provide that telehealth. And we do know that some of that is changing, as Taylor already mentioned. We have to make sure that the devices that we are using are compliant with HIPAA and network encryption to make sure we have security. And this is obviously very important for very many reasons. We have to ensure licensure for telehealth, and we have to be aware of what the state requirements are for each of us where we practice. We have to be knowledgeable of credentialing in our facilities. For our facility, there is not a special or additional credentialing to be able to access and use telehealth, but that may be different for different areas and different providers. Important to understand reimbursement. As I've mentioned, affordability is one of those barriers. And so if we don't understand reimbursement, then it may make it so that telehealth is not affordable. ensure connectivity, as we've already mentioned, and then consider if there are any malpractice insurance needs above what is covered under the regular malpractice insurance. And so in summary, telehealth in all forms has the potential, I'll highlight that, the potential to improve outcomes, but we have to make sure we are making sure that our patients have access, that it's affordable, that we are addressing digital health literacy to ensure equitable benefit so that we are not seeing those disparity gaps get wider. And then providers and healthcare systems must understand state and federal regulation to ensure compliance and security. Thank you for your time, and this is my email address if there are any additional questions for me. Thank you.
Thank you so much, Dr. Gillespie Bell. I'm going to pass it now to Dr. Faksh and Dr. Ajayi to discuss the work that they're doing in Power Mom.
Good morning, everybody. We would first like to acknowledge and thank the American Medical Association for the opportunity to present at today's webinar. We're absolutely honored to be here today. My name is Arich Faksh. I'm a board-certified obstetrician gynecologist specializing in maternal fetal medicine, and I currently practice at Scripps Clinic in San Diego, and I've had the great privilege and opportunity to collaborate with the Power Mom team.
Hi, everybody. It looks like we're going to have the same technical difficulties with our slides, so we're just going to roll with it. My name is Dr. Tuluwa Ajayi. I go by Lashay Ajayi. I am the principal investigator for the Power Mom study, and I am so happy to be here today to talk about this. And honestly, a lot of what we're going to talk about really builds up from what Dr. Gillespie Bell talks about when we talk about the importance of really bringing care to our patients, to the people that we care for, and really addressing that digital health literacy, affordability, and access. And so when we talk about Power Mom really is a mobile digital health research platform with the goal of building the largest, most diverse pregnancy-related research community. We want to do this so that we can not only inform and support pregnant people across the country so that they can be empowered with the data that they're sharing with us, but also really to share this data that we're collecting from this pregnancy community with those who have the power and the access to change the way that we reimburse care and the way that we change policy to improve the way that we care for our patients at the bedside. I'm going to turn over to Dr. Faksh to talk about really why we want to do this and the implications of this, and I'll talk more about the platform in a second.
No, thank you so much. So why is Power Mom needed? We all can realize here on this webinar that there are significant knowledge gaps that exist for pregnancy. So how can we work together to address those knowledge gaps and recognize the serious issues facing women and maternity care? The United States is the only developed country whose maternal mortality rate has been steadily rising over the recent decades. And this grim trend is a health crisis that truly warrants and demands our attention and focus, and also an enhanced understanding in terms of our ability to intervene and make a positive difference. In terms of the statistics, the United States among developed countries is ranked #1 in maternal mortality, and this is truly unacceptable. We've seen a rise in severe maternal morbidity over the last 20 years. Keep in mind, severe maternal morbidity includes unexpected outcomes of labor or delivery, resulting in significant short or long-term consequences to maternal health. Examples of severe maternity morbidity can include amniotic fluid embolism, cardiomyopathy, myocardial infarction, hysterectomy, blood transfusion. In terms of women who are at risk, data has shown that pregnant women of color are at highest risk. We see women who are Black 2 to 2.5 times more likely to die giving birth than white women in the United States. We also have seen since 2018 a rise in terms of severe maternal morbidity in our Hispanic population. We also see a lack of research in terms of maternity and women's care. Pregnant women are often excluded from medical research. We see disparities in representation, and variations in care creates adverse outcomes and higher costs. So what can we do together to address and intervene with respect to this national health crisis together? So delving into our state, the state of California in 2006, in response to this rise in maternal mortality nationwide, initiated the California Maternal Quality Care Collaborative, otherwise known as a CMQCC. The primary goal and objective of the CMQCC is to eliminate preventable maternal morbidity, mortality, and racial disparities in the state of California. The CMQCC has accomplished this through integration of educational materials such as toolkits, and also creation of a maternal data center, which is a robust mechanism to collect data on a variety of risk factors which can contribute to high-risk pregnancies. From 2006 to 2016, since the initiation of CMQCC over the initial 10 years, the state of California has actually seen a 65% decline in maternal mortality. So examining kind of the risk factors within our state, from 2021 to 2022, we've seen a rise in women who are advanced maternal age. In fact, 1 in 5 women in our state are above the age of 35 years old. In terms of other risk factors like diabetes, we're seeing a higher prevalence of women with diabetes. In fact, from 2022 to 2023, our pre-gestational diabetics in our state represented approximately 2% of the population, our gestational diabetics approximately 11%, with an overall diabetes rate of 13%. And then looking at hypertensive disorders of pregnancy, overall 17% rate of hypertensive disorders pregnancy within our state. And we're seeing these numbers steadily increase. So what can we do together to intervene, to have early detection, and to understand the different gaps in care to better serve our mothers? We delved into our Scripps data together, along with myself and Dr. Ajayi, to look at the influences of race and ethnicity in terms of the preeclampsia issue. Our hospitals at Scripps span four maternity hospitals in northern San Diego County at our Scripps Encinitas location. We have 2 maternity hospitals in our central San Diego location at Scripps La Jolla, Scripps Mercy San Diego. Then in the south, close to the border of Mexico, we have Scripps Mercy Chula Vista. On average, we see a higher rate of preeclampsia in our Black population in comparison to our white and Hispanic. So how can we better understand these variations, these differences, and kind of work together to be able to detect any issues earlier? So in order to better understand high-risk pregnancies and high-risk pregnant conditions such as hypertension, preeclampsia, elevated body mass index, women who have advanced maternal age, or diabetes, we do propose utilizing digital healthcare technology, such as the PowerMom platform, as a novel method and tool to really track maternal data with respect to being able to connect with a teleconsult, being able to monitor blood glucose levels, being able to look at blood pressures, and really collecting these data to intervene earlier and be able to understand different variations.
We know that this tool is a powerful tool. Like Dr. Gillespie Bell said, and Dr. Fach said, when we bring care to our patients, rather than making them come to us, we know that we can make an actual meaningful difference. And so that's what PowerMom does. Again, PowerMom is a multimodal mobile research platform. It's a bilingual platform, currently only in Spanish and English right now. And we know that this tool works to help, again, collect data, but also bring resources to our pregnant people, not just in California, but across the United States and the territories right now. So we know, according to the Pew Research data, that 90% of women own a smartphone. We know that 83% of Black Americans own a smartphone. And we know that 76% of Americans who are currently making 30% or less also currently own a smartphone. And these numbers are actually increasing as time goes on. So we know that a smartphone right now, even though it's limited, is a powerful tool, not only to provide care, but to collect information and partner with our participants to truly make a difference. Right now, and the slides are gonna be fun, we can broaden the research landscape with this tool. Right now, PowerMom, this bilingual research platform, has a baseline study just collects, again, biometric information by tapping into the Google Health Fit or the Apple Google Fit or Apple Health Kit data that collects basic biometric information. It couples that with baseline biweekly survey information, demographic information, and we collect birth outcome information from the mom. So again, this is completely driven with how much information the moms want to share with us. And then they connect their electronic health records if they choose to. This gives us a broad observational research foundational information. Then from this baseline platform, we can actually dig deeper and get more information. So for example, we actually launched 2 sub-studies to actually get more specific information. We look at PowerMom First, which we partnered with Fitbit, one of our partners, to actually collect information that looks at the impact of structural racism on the pregnancy journey. One of our other partners in our funded sub-study actually looks at how can a chatbot really impact postpartum depression. These are some of the later interventional studies we can do based off of this platform. As we're collecting this information and sharing this information, not only with our participants, again, we can then collect this information and share this with other payers to then reimburse, because we know that a Fitbit and Apple Watch can actually collect powerful information that can actually impact a mother's health. What you're seeing right here in this slide is a snapshot of what the moms experience within the platform itself. After they sign the consent, they get this nice intake survey and they get this welcome screen. They have different ways to actually visualize their data that they share with us, but they also get different resources from us. This could be actually resource information to other telehealth platforms from our different partners. This can be information about what to expect during pregnancy in the postpartum period, other clinical trials that are going on that moms may want to share their information to, because what we've learned in our pilot studies is that this is an engaged population that actually want to contribute to research. They want their voices to be heard, and they want to be empowered with data. So they want to share the information. They're just not being tapped into because, again, they're busy. But if we can bring the research to them, engage them in research in a way that's convenient to them, we can actually collect a huge amass of data. What are we actually asking? So again, at baseline, if they are a part of a healthcare system that already gives them blood pressure kits, or they already have a Fitbit device, they already have a Garmin or whatever, that actually integrates seamlessly with the PowerMom platform. So we collect that biometric, heart rate variability, resting heart rate, sleep, that kind of information. We also collect at the time of enrollment a basic health history. Then every 2 weeks, we get information about what medications they're taking, vaccine adherence, which is really helpful in a, healthcare crisis. So it allows us to be actually mobile about collecting COVID vaccine information at a timely manner when we were actually excluded in clinical trials. What can we get from then our community about who's taking the vaccine and what impact that's having in their pregnancy? We can collect information about pain, symptoms, and then of course, their weight, blood pressure, et cetera, et cetera. But then we collect information about their outcomes during their pregnancy. This slide right here that is very eager to show, and I just showed a sample of the data that we're able to analyze from everything that we collect. May is Mental Health Month, and so I just showed how those who are receiving treatment for anxiety and depression, what that looks like for those who are experiencing nausea, cramping, pain, shortness of breath, and what that looks like in this population. I wish the slides would stop moving so you guys can see this. And then this right here shows kind of what we collect as a resting heart rate throughout their pregnancy. Currently in the literature, there's nothing that shows what resting heart rate looks like throughout a patient's pregnancy period. If you superimpose this with information that looks at hypervigilance of what they're experiencing throughout their pregnancy, you can see what impact structural systemic racism, what impact bleeding, preeclampsia can have on certain outcomes and certain periods during their pregnancy that can really enable information to healthcare providers to intervene earlier, sooner, and actually make a difference at the time of impact. As we collect tens of thousands of informations and we have more people on this platform, we can then allow our participants to compare themselves to pregnant people similar to themselves over time using AI-enabled technology. but then they can compare their pregnancy journey to see how they're doing with ACOG recommendations and take this information to their healthcare providers who may not have time or the integration to look at the vital signs that Dr. Gillespie Bell is using. They can actually take this to their healthcare provider and actually implement their care or change their care as they're intervening with their healthcare providers. We can provide a digital twin for a healthcare provider, and we can share this information with healthcare systems so that they can look at their data and see what they need to do differently or where they can enhance on what they're already doing. Future data streams that we can incorporate within the platform include continuous glucose monitoring, blood pressure that we've already talked about, point of care, ultrasound, things like that that can actually be incorporated within the PowerMom Research platform. And I'll turn it back over to Dr. Baksh.
Thank you so much, and also thank you for everyone's patience with the technical difficulties and the slides advancing. So as Dr. Ajayi alluded to with the PowerMom platform, it's extremely powerful. It can offer a really seamless virtual experience, being able to collect a variety of data related to blood pressures, glucose monitoring, physical activity, maternal heart rate, to better understand qualitative measures with respect to issues faced by women during pregnancy, to better inform them about next steps and options. I really enjoyed this manuscript published by the AMA, Closing the Digital Health Disconnect, a blueprint for optimizing digitally enabled care. And this figure two really outlined kind of the different components of a digital experience with respect to coordinating care amongst clinicians, supporting a strong physician-patient relationship, enabling the home-based data collection, remote monitoring, incorporating a variety of modalities to be able to interact. And we want to take it one step further with respect to our PowerMom platform, which is really to create community-based partnerships. And we want to understand what the patient's perceptions are on the digital health technology and remote monitoring, better understand from the patient's point of view, what are the barriers to use, what are the facilitators to use, and what's going to help patients to adhere to kind of collecting this data and informing their providers of kind of next steps. And we hypothesize that this will really kind of help towards increasing engagement and empowering women to make the right decisions on behalf of themselves and their pregnancies. And with that, together, we will build the largest, most diverse pregnancy-related research community to best inform and support maternal health.
And you can see here, these are some of our partners. We talk a lot about the importance of kind of working together, right? These are some of the partners that we have to work with, that we need to share this data with. When we talk about access and affordability, we know that some of these devices that we use in our studies can actually make a difference in readmission rates and point of care impact. And their patients shouldn't have to pay out of pockets for this. So we collect this information and we partner with healthcare systems, payers. Can this actually be reimbursed? Can this be a benefit to our patients? They don't actually have to pay for this. As we work together with different healthcare systems, advocacy groups, patient organizations, healthcare companies, digital healthcare companies, to collect this information and share this de-identified data, this can make a difference for how, again, care is provided at the bedside, and really make a difference in the impact for our patients. So these are just some of our partners, and we're growing and would like to have more partners. So join us. And if you have any questions, we are here at, oh, you can't see that slide, but you have our contact information. So please reach out to us. And I'll turn it back over to Laura.
And I will share it. Thank you. I will share that contact information. And so sorry, not sure what's happening here with the slides, why they're kind of, as Dr. Fox said, kind of dancing on their own here. But thank you to our presenters for kind of getting through that. To Anisha's from Baby Scripts, who will kind of be sharing the company perspective. Yeah, I'll pass it to you.
Thank you, Laura, and excited to be here. So up to this point, we've seen some incredible data and presentations from a clinical standpoint, from a research standpoint, and from a policy standpoint. And I've learned a lot. I'm really here to provide the industry perspective to things, as folks might know, over the last 2-3 years or so, there has been an incredible amount of investment dollars, venture capital, private equity flowing into digital health. And the work that we're focusing on, particularly, some call it femtech, has also seen this huge surge in investment, and we're certainly grateful to see that and hope that continues. So I think industry is an important component in looking at any sort of transformation that's happening, particularly when it comes to tech. So my goal is to share a little bit about Baby Scripts. I'm the founder and CEO of the company, the work that we're doing, and some key insights we've learned in deployments and the products we're building. So just a little bit at the highest level about the market overall. I think that the statistics on the left, you've heard today on several presentations, so I'll kind of skip through that. But the one thing I did want to point out is that health systems, payers, care delivery providers across the nation are going through digital transformation, largely fueled by COVID and the impact that COVID has had on telehealth and remote health. Right. I think the interesting point here is that the users that we serve, the patients that we try and interact with, typically tend to be between the ages of 18 and 35. Right. So we consider them to be the tip of the spear. And quite frankly, a great area to focus in on to see good adoption of these technologies. So the rising consumerism, and oftentimes called the digital front door, is really driving a lot of transformation across healthcare, and we're hoping to kind of use that as a way to improve outcomes and quality overall in the pregnancy. So a little bit about Baby Scripts. We are a technology company. We've been around for 7 or 8 years or so, and we help providers, care teams, payers deploy virtual care solutions that can come in different forms and flavors, everything from a base level app that allows care teams to engage moms through their pregnancy journey to more high-end, kind of high-risk and low-risk pregnancy monitoring as patients are going through their pregnancy journey. But like I said, we've been around for several years, and in that time, we have built a strong foundation of partners and customers. So today, we're in about 27 states. We cover about 250,000 pregnancies across these states. We work with several health systems, several plans, and also hundreds of practice locations. And some of our customers are also investors in us because they see the strategic value in what we're doing. So how does the product and technology platform actually work? It starts very early on when mom gets pregnant. They get enrolled onto the Baby Scripts platform, and that allows providers to deliver some form of virtual care, everything from patient education, patient engagement materials, and then as appropriate, providers can enroll patients into certain risk-specific modules. This includes low risk and high risk monitoring when it comes to blood pressure, hypertension, postpartum. We do work on maternal mental health monitoring. We're not a traditional telemedicine provider, so we're not similar or competitive to a Zoom or other telemedicine solutions. We're much more focused on asynchronous remote patient monitoring and using mobile digital tools to deliver care virtually and enable providers to deliver hybrid care. Right. So in addition to the remote monitoring technologies, we also have things like care checklists, care plans, and other risk identifying mechanisms to the product. But the idea is to take mom through first trimester, second trimester, third trimester, all the way to first year after the baby's born, because we think that postpartum time period is actually really important. Because our entire company and our teams really focus on one episode, which is the maternity episode, prenatal postpartum. We've gotten a lot of recognition for our expertise in that area, and we've partnered up with our providers to do some scholarship and studies, and been published in several of the trade journals. At the end of the day, a technology platform like ours really drives a couple of core things. We start with engaging patients using mobile apps and digital technologies, but then that leads to our ability to improve active care, better outcomes for moms, and also driving a lot of operational efficiency from a practice standpoint. Right? Now, I don't want to use the rest of my time here to go into a big product spiel, right? I think folks can reach out to me or us to learn more about that. But really, I think what I want to highlight here is that, well, technology is a really important thing, and we're a startup, right? So we certainly feel the importance of it. It's really just one component of going through that digital transformation and change management. So with the remaining time that I have, I'd like to focus on some of the key insights and takeaways that we've learned over the last 7-8 years or so in actually implementing and scaling mobile digital tools at the practice level, at the health system level. And nothing here is revolutionary or novel, right? But it's just important to state because absent this, at the end of the day, we don't think we'll be successful. The first piece is getting very strong stakeholder buy-in and alignment. That includes both from the clinical and non-clinical side, and then agreeing on a set of KPIs. And I'll walk us through a couple examples of that. And the second piece is workflow, right? That ends up being such an important thing for us to be successful. But on the stakeholder buy-in and alignment piece, it's really important that someone at the clinical level, right, is working with us and has put the hand up and said, hey, you know what, this is something that's important to me for our practice, and I'm going to put the X in my forehead to try and make this happen, right? So absent someone putting up their hand and actually, being involved in, both setting up and deploying and monitoring technology like Baby Scripts, we end up sort of running into certainly issues as we scale, right? And that's kind of the central piece where we start with. But outside of that, it's also really important to get the buy-in from the technical side, right? So this includes the teams from the technology team, the CIO's office, the EMR, if there's other technology they use, work through that, and make sure that they're also bought in and agree with the approach that we're taking. At the outermost ring is all of the other stakeholders that go along with it, right? That includes, in certain cases, providers in the community, plans, payers, non-profit organizations. So this is a lot of work to make sure all of these items are ticked and tied before we actually have a go live, right? And that puts us in the highest level of success. The second piece and a good example of this is, and I'm not going to play the YouTube video to save some time, is we oftentimes call this the bake sale test, right? Clinical champion going to do a bake sale for us to get the product live, right? That speaks just to the level of commitment and passion and drive that they have. So, and a good example of that is Dr. Barker at Baystate. So once you have all of the stakeholders aligned, it's really, really important to make sure that everyone agrees on the metrics that matter and what are the priorities that are driving the implementation of those tools. Are you interested in streamlining and standardizing patient education? Are you interested in implementing new clinical guidelines, for example, the PAT guideline, right? Are you implementing are you interested in just improving access to care? What about the postpartum time period, quality benefits there, right? So this is an example of one of our customers, what they were interested in, right? But there's a whole menu list of items one can pick from. It could be around operational, it could be around brand, it could be around patient experience, right? So what are we trying to do? What are those KPIs? Let's try and get them documented and drive towards it, 3, 6, 9, 10 months, a year after go live, and see what we're doing, right? And see how we're doing and what changes we need to make to get to that. I've got a couple minutes here, so I'm going to skip through the last piece, but it's really, really, really important, which is workflow, right? And there's non-technical and technical components to it. When it comes to deploying a digital product, what folks on this call, the other presenters will tell you is that you oftentimes collect an order of magnitude higher amount of data than you do in a non-digital realm, right? You have your phone in your pocket all day, every day. You can go in and take a weight, take a blood pressure, answer a survey, engage with the app, right? So you're likely going to get a lot more information, right? Or at least a lot more information from a certain cohort of patients. Of course, that creates the risk of creating this information overload problem, right? And the last thing you want to do is add more work to an already, burdened provider staff, right? So from a workflow standpoint, we've spent a lot of time thinking through how do we elevate items that require immediate attention and that we call triggers, And how do we elevate items that just require just regular attention or feed that directly back into the electronic medical record? Right. So where are the exceptions? Where are these triggers? And who needs to get to them? Right. So that piece is really important. And on the technical side, which is, you know, how do we work with all of the systems and all of the other integration technologies? That's everything from, you know, basic stuff like single sign-on to working ourselves into the major medical records, whether it be Epic, Cerner, you know, through the kitchen sink approach, right? Old standards, new standards, you know, so on and so forth. You know, this is one of our customers down in North Carolina. They've shown great results with the implementation of baby scripts. This was in you know, actually a Medicaid setting where over half, a majority of patients were actually African American. We showed great results in the reduction of time to detect preeclampsia and also reduce the length of stay during the hospital stay. And the way we ended up doing that was we had the core baby scripts platform driving the engine there. But also at the same time, we were able to kind of create a system where alerts, both compliance and clinical alerts, get fed into Epic, but also led to a call center that we helped sort of stand up and let that information across to the care and clinical team, right? The bottom line of both clinical and non-clinical workflow, technical and non-technical workflow is super, super important. So that's it. That's just a little bit of our baby scripts and also just some insights and lessons that we've learned over the last several years we've done this work. If folks are interested in learning more about baby scripts, feel free to reach out to me, anishababyscripts.com, or you can check out our website. Laura, back to you.
Thank you so much. And I'm so glad the tech issues kind of resolved there for the last bit. But thank you to all our presenters. Really appreciate you joining us today and sharing about your work and what you're doing in this space. Here's my contact information and our director, Stacey Lloyd. And then I will say we have an active asynchronous discussion happening right now on our Physician Innovation Network. And this is all around the end of the PHE in telehealth. So we have a series of panelists, Taylor Platt, who you heard today, she's on that. If you have questions, you can go in and ask your questions and I'll ping the experts to respond. So feel free to check that out. It's in the widget, the link to this. And thank you all so much. Have a great day. Bye-bye.